Okay. I hope you remember that. That's our first ever outing of our homemade jingle. It's actually made by our team, made by the gentleman right at the back. So you'll hear it at every single event, every video. So you'll be tapping it and you'll probably hate it by the end of the year. But that's our new jingle, homemade for Friends of Europe. A very warm welcome to all of you. My name is Dharmendra Kanani. I'm Chief Operating Officer, Chief Spokesperson, but the privilege of moderating this very exciting panel of people, but also this discussion, timely discussion about the future of health in Europe and beyond. We have a panel of a range of backgrounds, experiences and sectors, as usual with Friends of Europe. This is what you can expect. We never keep it just one sector. And we want to engage with you in a dialogue about what we're saying, European, innovation in health for a brighter future. Its past has been very dim, as you know. The past 5 years have been incredibly grim. But one of the kind of, I suppose, factors in the state of health that we find ourselves in at the moment is the chronic disinvestment in health over the past 15 years. You all know this is not just a single country issue. You know that across the world, it's something which is quite interesting. It's a kind of sociological phenomenon. Why would politics and economics ignore our health and the quality of our health, knowing there's a real connection between quality of health and economic growth? But let's put that aside. But the reality is our infrastructure of health is extremely poor. It's not fit for the future. We know that actually very little attention has been paid to the potential of digitalisation to transform how we provide greater access, improve inequality, and increase the capacity of diagnostics and treatment and aftercare to be of a different level. We haven't even got there yet, let alone using robotics as well in the operating theatre. But the reality is, we find ourselves after the biggest shock to the health system, which is COVID, which upended everything. Everything we knew about ourselves, our societies, how governments would work, how the private sector would work. Who'd have thought that society would be underwritten by public payers' tax money? And the fact that suddenly both the private and the public would have to be underwritten by the public taxpayer. And suddenly we found ourselves in a place where it was a do or die situation, where vaccines were produced at, incredible speed and energy in a way that we'd never imagined before. Hospitals were built and all sorts of collaborations, innovations, and I suppose abilities to come out of the box that we've been living in for the past 30, 50 years. How is it that we can transform the energy that came about through adversity? How do you bottle that energy that came through adversity to actually do the most remarkable things, to be able to be creative, to overcome boundaries of borders, to create solutions during a pandemic? How do you bottle that and use that into be able to transform the future of healthcare? So that's the exam question these people have got to a certain extent. And we're hoping that you will have a view on it. And also just say thank you all for turning up. It's great to see so many people. And to say, this end is important, right? But your end is even more important, because if you didn't turn up, we wouldn't have a debate. So thank you all for being here. And hopefully you will be engaging. Don't be shy. If you are shy, I will call upon you. And I warn you in advance, those of you who catch my eye are likely to be asked a question. So suddenly don't all of you go like that, okay? So, but it's a bit, let's face it, this is a couple of hours of our lives we won't get back. So let's make the most of it. So on that note, let's start with Fabiana. We're going to take an Italian perspective to health. Fabiana, thank you very much for being with us. Can you tell us how, in what sectors and the approach you've taken to innovate and invest in certain aspects, or let's say sectors or types of health, to sustain, I suppose, the health sector in Italy?
Good morning, and thank you for the invitation to take part in such an interesting event. And let me bring the greetings of Dr. Giovanni Leonardi, the Secretary General of the Italian Ministry of Health, who couldn't be here today for previous institutional commitments. When it comes to investment and by Italy, we cannot avoid to mention the Italian National Recovery and Resilience Plan, which is part of the Next Generation EU program that the EU has negotiated to respond to the COVID pandemic. Mission 6 is dedicated to health, and in particular, Component 2 is dedicated to innovation, research, and digitalization of the national healthcare sectors. Investments goes through different lines. The first one is strengthening the research sectors by funding proof of concept projects with a low degree of technological maturity, as well as funding other projects on rare cancers, rare diseases, or other diseases that have a high impact on health. Another investment is on updating the technological equipment in hospital by substituting obsolete models with more updated ones, for example, angiographs, CT scan, MR scan, and so on, as well as also the informatization of the processes in a hospital. But also investment is going forward, the strengthening of the technological infrastructure, especially in the use of the already existing electronic health records, which is something that was already existing since 2012, but now is going to improve. And this will be very useful because, for example, doctors throughout the country will be able to see the same source of information with regards to the patient. And this will be very useful because, for example, we'll avoid to retake the exams more than once. And also, apart from the investment coming from the EU, there is also other 30.6 billion that were allocated through national resources. And there is one investment, and it's named Innovative Health Ecosystem, and it addresses to create translational and clinical research networks to improve innovation, and specifically the achievements that are to be reached are the creation of a network of technology transfer centers, but also the strengthening and developing of life science hub, and also the creation of a hub to fight epidemic and pandemic infectious diseases. This is already existing, is the Biotechnopole of Siena, which is already working. Thank you.
Thank you for that. So you outlined the kinds of investments. What's been the kind of, if you were to describe the policy approach, what's the objective been if you were to describe it, that Italy's approach to sustaining or innovating or preserving healthcare has been to do what?
Yes, actually, after years of defunding of the health care sector in Italy, it was being understood that we need to improve the innovation technologically, and because also there are lots of researchers in Italy, and but also the fact that we cannot work alone. So the clinical and translational research aims also at sharing with other states, because I think it's something that we learned from the pandemic is that no one can be saved alone. So still improve innovation, but also sharing the research and the results of the
good point. A point very well made about that collaborative practice that took place during the pandemic. Just one last point in terms of the massive resilience and recovery funding that was pulled together across Europe. Has any of that come into the health sector?
Sorry.
So the resilience and recovery funding that was released by the EU, to help member states bounce back from the pandemic. It was for, you've got some hundreds of millions or sometimes billions of euros. Perhaps it wasn't used in Italy for health then. Probably not.
Yes, National Recovery and Resilience Plan. That was what I was talking about.
No, but the money was from. No, but the money you used No, but was the money actually used for that purpose?
Yes, yes.
Right. Okay. Great. Thank you. Thank you very much. Thank you. Sorry for that confusion on my part. I'm going to move to you, Andrea, for lessons from creating vaccines, if you like, for a crisis moment in our times. What lessons have you feel that you've learned from that exercise, and what's the future now of developing vaccines for future epidemics, for example? What are the lessons you learned from the time? And then where do we move forward as a result of that, from your perspective? Where are we?
Thanks for the question, and once again, thanks for having me here as part of the panel. I'm really pleased to represent Novavax, and I would like to start by just giving some background to make sure that everyone knows who Novavax is. So Novavax is a global biotechnology company focused on developing and delivering life-saving vaccines to fight infectious disease. And we have been spent the last couple of decades refining our technology platform for vaccination and adapting it to a series of emerging diseases. And this worked positioned us very well when COVID hit in 2020. And we have been, despite being a small company, we have been the first company to bring in the market the COVID-19 vaccine that is based on a protein recombinant technology. And we are right now basically the only company offering a non-mRNA vaccine option that is adapted to the latest strains as recommended by regulatory authorities and the EMA. And I believe here there is already like an important takeaway, which is what has allowed COVID-19 vaccines to be available in a record time. It's really the decades of research that happened before. So they just didn't appear as a magic. There are other elements, of course, and we can discuss that more about that. But I think the kind of ecosystem in which we operate needs to be dynamic, well-funded, and there needs to be constant cooperation between private and public partners to allow us to respond quickly to future pandemic. Another element that I would like to highlight here today is the fact that COVID pandemic is over doesn't mean that COVID is not here still. And COVID is still a serious health threat for the system. I think look at the recent increasing of cases. I think most of the people in the room will know a handful of people that got COVID recently. Look at the new emerging strains that have been very concerning for public health authorities and that require the adaptation, actually, of the vaccines available in the market. And we see that the effect is still serious on both young and older people. So because COVID is still an impact on our society and eventually on our economy, we need to continue investing in the long-term management of the disease. We shouldn't forget about it. We know that the most cost-effective tool that we have at our disposal is actually vaccination. And therefore, we need to make sure that people know that and continue to get vaccinated. The model will change, obviously. What we see right now, and nobody has the crystal ball, but is probably a vaccination campaign that will happen in parallel with flu on a regular basis, on an annual basis, and targeting the most fragile people, so the elderly and people that have a disease. And looking at that, I think there are three areas for investment. So the first one is, vaccine alone don't protect people. We really need vaccination. So we need to ensure that there is a high uptake of the vaccines in a high-risk group and in target population. Unfortunately, in Europe, vaccination rates vary significantly among countries and even within the same country sometimes. And therefore, we need to work on three key areas. One is increasing vaccine confidence. There are still a lot of people that are skeptical about the safety and efficacy of our vaccine.
Yeah.
And I think there we are having a differentiated options in the market, which is what we offer, can actually play an important role in increasing the confidence. The second one is there are a lot of people that are not vaccine hesitant, but are not getting vaccinated because perhaps there is a bit of vaccine fatigue overall. So we need to fight that complacency and making sure that we have effective campaign to vaccinate people. And the final one is convenience. So we need to make vaccination easier and accessible, working with pharmacies, GPs, to allow people, to get vaccinated in the best moment for the day and in their daily life. Another important area where we need investment is in continuing ensuring that a diverse portfolio of vaccines is available. What I mean is having different type of vaccines from multiple suppliers, and that has a number of advantages. I spoke already about the confidence piece, but I think there is a broader element of healthcare professionals being able to provide patients with, the best solution for that specific patient. But there is also an element of having a strong supply chain, and perhaps this will come back in the debate. But there has been a lot of discussion about shortages, and I think if we rely on one vaccine, we increase, unfortunately, the risk of shortages or late deliveries, for instance. And there is a broader element of competition in the European space that I think is healthy overall. And this is an area that has been highlighted by the European Parliament, that has worked on a report on COVID-19 lessons learned, has been highlighted by the Court of Auditors, but there is still a long way to go in Europe for that. And the final point that I want to raise is investment. So we need to continue investing in the next generation of COVID vaccines. And when I say we, I mean the private sector, but the public sector as well. I think healthcare professionals and citizens are asking us for, more convenient vaccines that protect us better and for longer. And so we need to continue investing. And this is an area where Novavax is doing a lot of work right now, focusing on a combo vaccine, bringing together in one shot influenza and COVID, which is going to make vaccination much more convenient going forward, because the target population is the same and everyone will hopefully get the 2 shots.
Great.
Thank you.
Thank you very much. Do you feel that the collaborative practice that was taking place to be able to generate a vaccine, so the R&D element that people shared, so China shared its stuff from where where the bug was, well, not originally, but countries were sharing their understanding of the bug, if you like. Is that still happening, or have people gone into silos?
I think obviously, there has been some challenges during the pandemic as well. It wasn't everything working well, but there was an alignment of intent there that has been very powerful, and that is actually what has allowed us to get vaccination available very quickly. And it was at any level. It was from public support to R&D to speeding up clinical trials to having a more agile regulatory framework, so a constant dialogue between manufacturers.
But is that continuing now? That's what my question is, really.
Not to the level of the pandemic, obviously. But I think it's actually very important that we take some of that lessons and we try to apply it more, standard and non-emergency situation, because I think there are a lot of important elements that emerge from.
As a global company, are you behaving as you would like others to behave in your, if I can say it that way?
Yes, I think we are.
Of course, the question and answer would be yes from you. Yeah.
We were, let's say, lucky enough to live through. And I don't know if lucky is the right word, but we live through that moment of collaboration. So we try to continue working very closely with authorities at different levels to make sure that we can provide solutions that work for the system. Absolutely.
Okay, colleagues, we have a couple of minutes just to open it up to you if you have any questions or reactions. Of course, indeed. Sir, quick off the mark. Just here. Davide, just here. Please say who you are.
I'm Andras Laszlo. Allow me to be a bit provocative, because this is mainstream. This is your mainstream narrative. You said the most cost-effective tool is vaccination, increase vaccine confidence. But what about the side effects of the vaccination? People are getting sick. People are dying from vaccination. What about that, sir?
Okay, that's that. Any other question? In terms of your just kind of current awareness of the rate of infection, or we're all coming across people who are coughing like mad, or taking 3 or 4 days off and thinking, is this COVID or not? We don't really know, and because the public campaign, the public awareness is gone, we're not getting the regular announcements, etc. So there's something about lack of awareness, but also a sense of urgency, or even the need that we should be going to get a top-up or another vaccination. I don't know, any reactions to any of your personal stories around that? Great. I was going to say, is it too early in the morning? Thank you. Say who you are.
So, Simon Brake from the University of Warwick, but also working in local health services. So, from a local health services perspective, we're absolutely aware of COVID. It's coming through our front doors and occupying our beds at an ever-increasing level. So,
right now? Is that happening right now?
Right now.
Wow.
So, and that's been the case for several weeks now. So the numbers are, rising. They're higher than they've been for some considerable time. And I suspect all healthcare professional colleagues in operational settings are experiencing the same thing. So that's happening right now. We've got lots of campaigns to give those who need it vaccinations, which are seeing take-up lower than we would want. And that's concerning. We've got lots of people using stockpiled, out-of-date LFD tests to find out if they've got COVID, which is unhelpful on a number of fronts. And people following their own guidance around self-isolation or not. So what we have is a kind of a policy vacuum and a disinclination to discuss it at a government level. But the truth is, it's being experienced every day, both in the community and in our healthcare services, and people are terrified about it. So it's definitely a presence in our lives, and we need some policy coherence. Now that's a local, regional and national government.
But also some sort of continuity of the importance of not underestimating the fact that the bug is not gone, and it keeps on mutating, and it will be in our lives.
And if you look at national risk registers and threats, pandemic is certainly in the UK, is still at the top of the UK risk register.
Well, no, I mean, the UK is a bit of a bandpot at the moment, let's face it, politically, but but
it's at the top of the risk register, but nobody's talking about it. And that's also, one of those kind of perennial problems. But yes, and it does need to be raised in our consciousness. Very much agree.
I mean, Andrea, do you want to come back to that, or any of you want to come back to that point?
No,
about,
I think is, yes, absolutely. I think, I'm not a scientist, I'm not an healthcare professional, so there are better people in the room that can talk about that. But I think science speaks. I think no other vaccine has been used as much as, the COVID vaccines during the pandemic. We know about some side effects, which are, normal about vaccines, but is really minimal. And, the cost benefit of all vaccines for COVID-19 is still very positive. So I'm not backing on that, and I think we should not have doubt. I think right now we are lucky enough that we have different vaccines with using different technologies, and I think these offer a possibility for everyone, even those skeptical about a certain technology, to get protected with another one. And these are all safe and effective choice, and luckily we have a number of that, and we should continue getting vaccinated.
No, sure. But there is something about, and I'll move on to our next couplet, if you like, of contributions, that we have a shortage of medication per se. This is likely to increase across Europe. You've got people with out-of-date kits currently, and they don't know where they're going to get more, where they should go and get the kit for vaccination. So there's something about the fact that we're taking our eye off the ball collectively in Europe, potentially, and in the UK and elsewhere, that actually the problem's gone away. But did you want to come in as a politician on the point? I'm going to bring you back. So this is our minister.
It's really fast, I mean, if I take just, our case, and it's a mid-sized European country, just from the January till now, we had around 15,000 patients who were in the need of the antiviral treatment.
Oh, wow.
And if you take the cost, which is, for the treatment which is available now, we have one registered, one non-registered. The price is similar. And compared to vaccines, then, of course, the investment is supposed to go certainly to the vaccination. And the second point, which I would like to mention, is where we are. I mean, as a Europe, we succeeded, with amazing task to purchase together, to negotiate together. But at the end, we finish it, with this quite a complex situation where, let's say, the majority of the European countries has one supplier. As if you take the contracts, it was managed, in 2020. Of course, at the beginning, it was definitely positive for states to get enough. But at the end, now we are at the stage, where we have too many. We are burning vaccines in millions of doses. And we have, if I take, the public investment, which I'm responsible for, I cannot purchase, for example, extra vaccines. At the moment, I have already the order for coming 3 years, which is fixed, and I have to use them from one company, one technology, and I cannot come for the additional technology because it's just already purchased. And we are coming to, I would say, something like the vendor lock a bit in Europe. So it could be, it could have an impact, on the R&D, it could have an impact on the availability in the future, and also the trust of the patient.
We'll come back to that because you've just, hatched open this major problem about how the market works. And if you have to purchase that far in advance and the limited nature of, access to multiplicity of providers, I mean, there's something wrong about how the procurement process works. But we'll come back to that. Nina, I want to come to you, if I may. You do, I mean, the topic is about investment, health as an investment. You do a lot of, investment. You're a venture capitalist. You've a lot of experience in this. You've focused on issues around gender as well. From your experience now at the moment, what can we learn or what should happen? So there's what can we learn and what should happen in relation to looking at investments, both from a kind of a collaborative manner, public and private. So that is there a different space emerging where it's not simply about the public sector coming in and providing, let's incentivizing investment?
But again, we cannot solve this if it's not an EU. We had a session this morning about a young company who's trying to scale a next generation diagnostic in 27 European countries. Frankly, it's not competitive from a commercial perspective, and I don't think it makes sense. So this whole honest conversation from the government level around what can we do together versus alone. From the industry perspective, I think this thing about just blindly raising prices for innovation is frankly unsustainable. Rarely in medicine are things revolutionary. If you cure blindness with one shot, let's talk about the $2 million therapy. But for the vast majority of innovation coming to market, it is incremental, and let's have a conversation around
10 hospitals in Europe, every €4, one is wasted. Again, maybe to have the question to say, can we better use that money? In both cases, are no new money needed. I cannot afford it. That's why my reaction last night when I hear I cannot afford it. Actually, you are spending money, but badly, wrongly, in a very not convenient manner. Neither for patient, nor for the system, nor for the citizen. So in this way, how we can review? We can review public-private partnership, to your point. The private part very often owns the innovation. Innovation in obsolete processes will never produce the outcome expected. Processes perfect with no innovation, I mean, yesterday there was the example of the empty hospital. An empty hospital works very well, obviously. No? I mean, there's no reason. So I think that this combination public-private, if we take it out of the theoretical academic space, but we put on the ground and we start to say, is the way of test and trial transformational innovation in real-life setting. Is where really we manage. The example of the vaccine has been quoted several times. There are many others. There are 18 public institutions with 6 companies involved in IHI, innovative healthcare initiatives in Europe, 21 million on early feasibility studies, how to take early research, first in human in Europe, back, develop knowledge, event center of excellence. These type of things. You have the money, you test, you learn, and you move on. The risk is that this discussion of, and I'd say very, as I am, I don't know, kindly, but health as an investment, is a cost of an investment. It's been a long debate, but I think it's the assumption wrong. Health, the bottom line is us. Is the right of, you were talking living longer, living better, is all what we do. And it doesn't matter the gender, the generation, where we live, rural, big cities, etc. So is the natural use, a better use of resources that we put there. But we should not fall in that very negative and dangerous approach. I cannot afford, I don't have money, how much it costs. Look at the money that we are wasting, that we are misusing, and let's do a better work. Put around the table, as been said, the critical stakeholders, but not just let's discuss the solution. So who cares? Show me, model, test and trial, how you can do an early detection, how we can better understand. If you do early detection on several diseases, you can stratify the risk of your investment, because you know where the population is going. So it's not just checking. So that's the story from my side at this stage. I want to just use this for Andrea, not only because we share the passport for this gentleman.
We have a lot of Italians on the panel.
Yesterday morning, I got my 6th COVID vaccine. I'm in perfect health. I'm very happy. And please, I don't want to open any discussion with you, sorry to say, but I want to hear fact and data on science. When I hear people is dying by vaccine, you have to show the correlation in a peer review publication. Sorry to say, otherwise became chatting on the street and is unfair because there are life of people. I can take after if you want, when we finish.
Great. Thank you very much for, again, isn't it great? There's a lot of passion on that panel and a lot of thoughtfulness. And I'm going to bring some of you in. Andrea, I just want to ask you one thing. You know that thing about, is anyone looking at the model of how hospitals work at the moment and doing kind of like, these are the inefficiencies, this is the waste in the system? Because when you go in, either as a friend or family, and someone in A&E or visiting somebody, you can see the waste, you can see the inefficiency and the overwork, and the fact that because of risk, you've got lots of handovers happening in the hospital, and it's just it's an absolute nightmare. From your experience, are you seeing anywhere that's actually thinking about business reprocess engineering?
I'll tell you something that is even more interesting. Behind all that of this discussion about the money available, the big numbers I was quoting before, is actually that in almost all European countries, budget and public budget are extremely built on silos. I can take, yesterday Giuseppe was saying, hey, it should be cost effective, you have to show your cost effectiveness. I'll take an example on a product, I'm not quoting the product, in a major European country, which is France, so I'm not saying sophisticated, I'm not taking the most marginal or... On this product has been shown based on those rules, the cost effectiveness, dominant for people who knows about this technicality, it means that every patient that was treated with this technology, there was a saving of 10,000 euros for patient. So every time that you move. The answer was, it's great, we ask you to do, but unfortunately it's not on my budget. That's the public hospital budget and not the innovative product list. And you say, I know, but I cannot fix the fact that you are unable to move money from one envelope to the other envelope, or at the end are pockets of the same pair of trousers. So, that they try to keep separate. So that's also, we want to introduce innovation in healthcare system. We budgeted the word design and structure 50 years ago. That's the real problem. So appreciate the value and the impact is very difficult.
Yes, and there's a kind of, this is a personal view, I think that something about the creation of an internal market in healthcare or in health provision has, I'm not saying I'm against that, but it's bastardized the system in a way that we can't seem to pull back. And it's created this nonsense of budgeting, but also multiple service providers in one institution that actually don't even speak to them, with a faux sense that will be more efficient and effective. And here we are. We have questions yourself and yourself. So the mic over here, please.
Hi.
Please say who you are and what your question is.
I'm Evelien Scheres. I'm the General Manager to the European Kidney Health Alliance. I was wondering if we are rethinking models, how prevention gets a place in health investment, because the word was not mentioned once by anybody, because vaccination is very important, but a healthy lifestyle can prevent 40 or 50% of the diseases we are talking about here. So I would really like, and if you are sandboxing, please consider prevention, because I'm from the Netherlands, and the first thing governments, I don't know how in Czechia that is, cut out is money for prevention. So all the money that's wasted in the hospital, can we spend that on prevention? And also team up there, because GPs and people in hospitals still don't give lifestyle advices. So I really would like to know whether prevention is also considered in this health and investment question.
Very good point, and absolutely. I mean, as they say, an ounce of prevention is more than a pound of care. And so absolutely, it should be there, and we should talk about it. Because the thing is that it's one of those things that if you can't touch it, politicians can't see it, you're healthier, you're kind of fine, you're free of ill health, you're not an issue. And that's one of the things that there's a mindset issue that we need to overcome.
Yeah, but also there is a lot of proof that healthy lifestyle works.
Absolutely.
But all these figures don't matter. It's also how the system works. So there also needs a system changes. And I think if companies like the people who are representing here are also willing to sandbox on prevention together with the public and private organizations, that really should be a game changer.
Thank you very much for making that point. Can I have the mic? We seem to have only one person with a mic for some reason. Sorry about that. If you just come to the front here.
Good morning. I'm Birgit van Hout with the United Nations Population Fund, UNFPA, and I would like to connect SDG 3 to SDG 5 on gender equality. I have two questions, but very quickly, before I ask my questions, 3 facts. it is a fact that during COVID-19, medical interventions for women's public reproductive rights were deprioritized. Secondly, some EU countries have lower HPV vaccination rates than middle and even some low-income countries, even though cervical cancer remains a key threat for women's health. Third fact, research and development remain very much a male-dominated field, with, according to our data, only 20% of graduates from STEM subjects being women. So my question to the private sector representatives here is, how can we apply more of a gender lens to research, development, and innovation? And my second question is about COVID vaccination, which you talked about. Yesterday I was at a panel where someone quoted Martin Luther King, who said, "Nobody is free until all of us are free." And I would like to paraphrase that by, none of us are safe until all of us are safe. So to the policymakers, I would like to ask, how about COVID vaccination for undocumented migrants? Are you including them in your national plans? Thank you.
Birgit, as ever, thank you very much. Incisive. And thank you for being here and making that point, which has also been missing as the prevention one. Thank you. Lena, again, introduce yourself.
Yes,
please.
Thank you very much. Very inspiring discussions. My name is Elina Drakvik, and I'm from the Finnish Innovation Fund, Sitra. And I also just wanted to respond to your intervention about the prevention, because we also think that it's a key issue. It's a cost savings, it's cost effective. And I just wanted to mention as an example that we at Sitra, we also fund small scale pilots. So we have been funding a data ecosystem that has been working on memory health, prevention of memory disorders, but also delaying the onset of the disease. And we have been using, or the project used social impact bonds as a model. So there are new models that can be used. We need more examples and best practices. It's still in a piloting phase. The work will continue. It's not complete. The next phase is this implying the multimodal lifestyle intervention that is based on finger model, peer-reviewed evidence-based model. And moving towards this outcome-based model as a whole. But I think we need more concrete examples how this can be applied and these regulatory sandboxes also at this level.
Great, thank you very much. Thank you. Please.
Björg Parsottir from the Training for Health Equity Network. Great conversation. And building on some of the comments here, I think it's important to talk about COVID, but don't we really want to use this opportunity to make structural changes, both in terms of the equity issue, whether it's gender, migrant populations, how do we then reduce vulnerabilities of these populations? But also I think health care isn't going to happen without the health workforce. And what are we going to do both into investing in them and making sure that we're supporting them? We know the challenges with burnout and lots of other issues, and I think we need to think in the long term how we do that.
Well, fine, but can I just hold the mic on? What would you like then from the Commission? What would you want the Commission to do, the EU mandate for next year on, because your elections mandate setting a new policy agenda. What would you want?
Well, I have recently returned to Europe, so I don't know all the details, but I think we need to think holistically, whether it's around, and we need to get the right people in the room, as has been said, and including beneficiaries and the health workers so that these perspectives are included.
Great, thank you. I'm not going to ask all of you to answer that or individually. Let me come back to you, because there's really quite good structural questions which cross across all of you, because I'm conscious of time and I need to move into our last couplet. So I'm going to turn to you. Do you want to say something very briefly? Yeah.
On the prevention, I think you're absolutely right. It's an insult that even before COVID, the world average in Europe dedicated 0.5 of the resources. So absolutely an insult. What I would not do is to use prevention as kind of an alternative to treatment. No, I'm just saying, not you, but in general. In terms of, say, a balance, you were referring before to early detection. For instance, if you have an early detection of cardiovascular disease, first of all, you know individually and collectively where your population is going and where you are going. It can be that then you have an healthy lifestyle, you correct your lifestyles, and you go till 100 years old. It can be that at a certain point you need a medical intervention. It can be that at a certain point you need a pharmaceutical or a technological intervention. But you will do all in time. So you will reduce also the impact on the individual life, getting to a treatment too late, or the cost that's combined. So I think that is really this unicum from prevention to treatment, but having that in a regular phase as a real investment.
Thank you very much. I'm going to turn to our Deputy Minister for Health, Jakob. Data is important, we know. Data is, all seeing, all knowing, but we need to make sure that we can use it properly, share it properly, and make sure it's used with intent to actually reduce inequalities, reduce healthcare needs, etc., and so on. What tools are available to you within the state, if I can call it that, to, I suppose, lead the way in investing wisely, so that we're able to move in a way that helps us on this, investment, health as an investment, which is a very different mindset. So if you can speak a little bit to that agenda about what the state can do in this territory.
No, thank you for the invitation, first of all. I would try to address, what you mentioned. First of all, number of answers which are let's say, ready, for your questions, could be done at the moment. We will know where we are going. And luckily, the Europe, did this first step, with the European Beating Cancer Plan. So that was the first step. Unfortunately, we stop, with this first step. We are not moving further, with the other therapeutic areas. So we don't have a European plan for cardiovascular. We don't have a European plan for rare disease. Unfortunately, this very right move to somehow put, the national plans, ideas, visions together, and to create, the comprehensive response, which will be able to somehow address the need of prevention. Also, at the moment, we will be able to work with data. We will know exactly where to invest. If we know, that the screening of any kind of oncology disease, saved so many lives, and also save, the early diagnostics, save, so much money, for the states, then of course we can save a lot. We can somehow manage, those gaps, the investments without return. Unfortunately, as I said, we stop with the onco. And I know that there is a lot of initiative to move forward with any other area, mental health, neurodegenerative diseases, etc., etc. Somehow not enough resources. There is a lot of reasons why not now. I believe, if we are coming with a new legislation, we're coming with a new pharma package, with European Health Data Space, with SOHO regulation, there's so many important legislation in the move now in Europe, and also for the next European Parliament. We just have to take, what we have already, and to use it properly for other therapeutic areas, and to invest, with sense. And this will, brings all the answers you seek for. And, when I prepare, for today's meeting, I try to really think, about some case study, which I just, have to move through that case study recently. And, the Czech Republic is the country where we really allowed now the access for innovative technologies in a number of fields. A small country, not really rich one, but we are now number 11, in the access of the rare disease, the new oncotherapies, etc. But do we really receive enough back, at the moment of investment? We increase the health budget 10% every last 3 years, 10%. Do we get the 30% back in the efficiency, in the better health of the population? Not really. Very often we are investing to the areas which are not bringing back, the results we would expect. The reason is that in a number of fields, when the technology comes inside of the system, we do not have the exact data and exact information, how this technology will work. And my case study works, with one therapy, which is now available for, let's say, a year in Europe. I wouldn't name the drug, but it's most expensive drug. Now, the most expensive one. We have first 2 patients in the Czech Republic. And when I get through the data and the conditional registration at the EMA, I'm at the European Commission, what I get is not the clinical trials result. It's casuistic, it's case study. It's really, very, very weak data. And we're investing 3.7 million euro for patient in this case. I'm using that as a case study, but there are a number of other technologies which are coming to the system with very weak data at the beginning. And for us, for those who are responsible for public budgets, it's very difficult to decide. We don't have a willingness to pay threshold in the Czech Republic. So no limit. If you come with a new technology, we have an individual reimbursement. If it is only therapy for you, then we will pay for it. Even for the refugees from Ukraine and from other countries, because we consider them as a state injury. So all of those therapies are fully available. But when I come back, when I try to see what we get, that's a big problem. Now the number of new technologies coming inside of the system have very, let's say, data which are, on small groups of patients, very often for very short time. And somehow, we are spending a lot. And it could be, those very costly therapies, but it could be also the vaccination, also the prevention. We have to really understand how we invest the money in the healthcare, because I believe all Europe is now investing a lot in the healthcare. Doesn't matter whether it's Italy, France, Germany, or Czech Republic. Based on the learning, from COVID, from last years, I really believe we invest all possible money available, not just the recovery plan. And in the Czech Republic, the part of the recovery plan dedicated to healthcare is 1 billion euro for 10 million population. Oncology, prevention, early diagnostics, etc., etc. A lot of money. I just do not know, if what we will receive back will be worth to it. So that's my message. We have to really start to think, how to work. And if everything works well, I believe that the European health data space will come very soon. It should be approved next year. Then few years, for the implementation. Again, it will be a huge investment from the national budgets. But maybe, if everything will work well, we will be able to see, how we invest and what we are getting back. The secondary use of healthcare data, this is for me really the number one. Not, for the research. Of course, it could be, if the academic will sit here, he will say, yes, it will be the holy grail for research. But for us, for those, I'm not a politician, by the way, but anyway, but for us, who try to somehow manage the investment in healthcare and public health budgets, this is the only chance to see, how we invest and if our injuries gets, what they pay for. And then, my message for the next parliament, we have to move it very quickly. But on the other hand, just be very cautious, that we will not make any other, let's say, problem like we did with the medical devices, medical device regulation. This have to really work. So, there will be still a lot of work for anyone in this case, and then, this follow-up is the pharmaceutical package. If I take the small country or mid-sized country like the Czech Republic, those marketing authorization holders who are coming, to the European market, they talk to Italy. They talk to Germany, they talk to France, they do not talk to me, not to my regulatory agency. We are a 10 million market, maybe 5-10 patients. But if you don't have a chance to come, to make a deal, to make really some kind of a good agreement where we will pay for performance, not for the dreams. Because if we will continue to pay for dreams, we will very soon finish, with disaster. And that's my worry, and that's my also wish, for the next steps of the European Parliament. We have to finish the pharmaceutical package very quickly.
Jakob, thank you very much. And thank you for bringing that, because you've harnessed a lot of the contributions we have around the table, and especially building on what Andrea and Nina were saying around a different mindset, especially that, the whole point of calling this an investment means that you have a different mindset to what you're doing. You are looking for a return, a social, but also economic return. And so perhaps we need more of that mindset to be prevalent in Europe. You're a Deputy Minister for Health. What do you talk about with your other Deputy Ministers for Health in Europe? No, really? Because I was thinking that, you're talking about that.
Of course.
You have an opportunity to influence other states, no?
Yeah, sure. But if you really ask me, what is now the hot topic for all of us?
Yes.
The availability of treatment, very basic treatment, very basic pharmaceuticals, penicillin, syrups in penicillins. Can you imagine it? After those years, we discussed the how to get the innovation, how to pay, for rare disease, etc. Now the half of the time we invest, to really find a way to how to survive in the new environment which is very unpredictable, with very, very basic treatment. Not just, the pharmaceuticals.
Yeah.
It's also the area of medical devices, many other fields.
So it's basically primary care type of stuff. Almost like we've gone backwards, that it's access to things like penicillin.
The system becomes, all pharmaceutical production and supply chain becomes very unpredictable. And that's, I think, the big issue, for all ministers of health. Mm-hmm. And it's not about the money. You could have money, but you cannot buy it. You are in the stage that you are really talking about a one box, one package for €10 price or something like that, which is nothing, for the national budgets. But you just cannot buy it because there is not enough for the European market, that's all. And that's a pure nightmare for all of us to manage, the basic primary care, the access to the treatment, like the basic antibiotics. Can you imagine it?
Why is that? Just explain to us, teach us like children. How do we understand how that's happened?
Why this happened? I don't know. You have to ask the industry. But in this current situation, I'm asking every day, all those big companies, producing,
are they choking the market so they can get more money, basically? Oh, okay.
They would like to get more money, but as I said, it's not about the money.
Okay.
If you increase the price, for such a product, 15, 20, 30%, it's not the issue.
Okay.
It's just, there is no enough production in the Europe, for all those patients who suffer with basic infections.
Yeah. So it's really quite startling, isn't it, that these health ministers are talking about something so primitive that we thought we could have solved decades ago. I have very little time. I have less than 5 minutes, Anka, but you're not going to be curtailed because we've left you to the last to bring a patient perspective to this as opposed to starting with it. So you've heard a lot, Anka. You've been in the game, in terms of trying to enable a patient perspective to be taken on count of, heard. From your perspective, as you look ahead, what needs to give? What needs to change to improve a sense of trust?
Thank you. It's nice to have the last word, even if it has to be short.
It doesn't have to be short. No, it's
okay. I will not. I'll just keep you away from your coffee. Good luck, everyone. I saw the 5-minute sign a few minutes ago. Anyway.
That was for me, don't worry.
What needs to happen to improve trust? I want to go back to the basics. Okay? We are here to talk about health as an investment. We are here to talk about health in economic terms. And my question to you all is, does health, as a cost, as an investment, count also as an economic sector? Because if it does, then I want to behave like a shareholder in the healthcare system. I'm your shareholder, Jakub. Yes. Okay? Income taxes in OECD countries are about 30% of the total GDP, right? So I'm a shareholder. And as a shareholder, I expect the return on my investment, and my dividend is my health. Okay, let's talk about health in economic terms. Does that seem right, though? Is health about economics, or is it about human rights? If we accept that universal health care is a human right, then I also want to reject this particular view, but I can make it work. I'm your shareholder, The next question I have is, can we make the economy or this economic model of health deliver for people? Or do people have to work for this economic sector to thrive? What comes first? If we are going to accept the economic model of health, and we're going to accept that everybody has to work for healthcare to be a booming economic sector, then we think about things in a certain way, and then we can quantify everything, and then let's use metrics for health, and then everything is measurable, and everything translates into money. But when someone is born, when your child is born, when my child is born, what do we most wish for that child? It's health. That's priceless, but it's not valueless. So I'd like to, go into this sandbox, starting from the values that we are here for, and then think about what are we trying to achieve, which is better health for everyone, whether it's through prevention, in which, Evelyn, I believe so much from my background, and it's just such a fundamental thing, to the treatment which cannot be neglected. There is not an either or. Health is one health. Health is everything. Second point that I wanted to talk about is, and it was raised before, involve the beneficiaries. Well, that's citizens and that's patients, okay? If I'm a shareholder, I expect to be invited to the shareholder assembly. And EPF, as an umbrella organization, expects that as a representative of the shareholders, one of the representatives of shareholders, be invited at the table in your sandbox. You see, I'm in your sandbox now. This is not, it's an economic right. It's also a democratic right. And it's also about trust. And that brings me to your answer, Dorenda. And then the third thing that I wanted to say is, for this to happen, there is an investment that needs to be made. And an investment in health education and health literacy. In order to trust science, people need to trust at least the process, the scientific method, the scientific process, in order to avoid misconceptions and misinformation and deal with the infodemic and with all of the misinformation circulating. We need to have at least a basic level of health literacy and of health information for everyone. Now, everyone is 400 million people in the EU. So we are talking about a significant investment here. But if you want to have your return in good health, that's where you start. That's where you start. There you go. I got all fired up, but I'm using my last
but you had
word.
everyone fired up.
There
Everyone was
you
like
go.
listening to this woman say, wow, who is she? It's great. No, thank you. So I need to finish off, because I'm sorry, colleagues, but it gives you enough opportunity to have a really good conversation over coffee before you come back. But what's your ask? I want each of you to, in 60 seconds, say, what do you want from the new mandate? And I say to all of you, I'm sorry I haven't got a flip chart here, because you could just write what you want. Perhaps we can create one. But if you have a thought and view of what you want in terms of health from the new EU mandate, either email us at Friends of Europe or put it on #FOEdebate, and then we'll log it there and we can do something. But it'll be really important to have this engagement from you. What should we do? Because what we're doing is we're pulling together a set of policy choices for the new mandate, and we're going to launch them in November. And one of those has to be around health. So your views and ideas will be most welcome. So, Anka, what do you want?
Okay, so we had, when COVID started, we had this massive realization that we need to invest in health. And a lot of investment was made in a reactive way. I think this mandate, what I'd like to see is a bit of proactive strategic thinking, starting with the key values and the key objectives and the very basics that we want to achieve, and use everything we've learned to have a long-term vision for health in Europe.
Okay, thank you. Nina?
So it's been commented by several people that in the State of the Union there was very little mention of health, and I think we need to change that. Call me naive, but I really want the people that are powerful enough to create change, but also visionary to believe that change is possible in the room. Let's talk about how we actually team up, align incentives, and actually deliver better health for all of European citizens. If anyone thinks I have anything to offer, I'm raising my hand. I'll be part of any type of working group.
Isn't that great? Good for you. Good for you. And Andrea?
For the new Commission, well, for the next mandate, it's not only the Commission, it's the Parliament. As I said before, if we spend 282 billion in cardiovascular diseases and it's still the #1 killer, it would be great to have a European plan for cardiovascular diseases and see if we can use better this money, no more, but better this money, and absolutely reduce and make this disease maybe #2, #3, #4, #10 killer.
Okay, great. So we've got, make sure that you actually take a values-based approach and a long-term view. Let's sandbox and get as many creative, powerful people to come together. Let's have a plan on cardiovascular disease for once, a coherent plan across Europe to actually then do the thing that you've spoken about. But moving to you, Jakob, what you're talking about is how do you get the return on investment? So what's your one ask?
No, I think I already used my opportunity during those.
Share it with us
messages.
again. What's the one thing you want?
Let's really focus, not just on the cardiovascular plan. Don't do that again, just like one unique area. If the cardiovascular will be not first, then will be other first killer in Europe. So we have to have really the comprehensive view how we will deal with the key areas which are killing the European citizens. And of course, I would like to really have the focus on the new pharmaceutical package, and really the vision, how this new environment is supposed to work. It's not there. We have to really move it forward. And I will use the last 15-20 seconds, to respond to Anka. We have the shareholders as patients in the Czech Republic. We have them in the rare disease pathway. The patients are not just the review of the new pharmaceuticals coming, but they are also the part of the decision-making process. And I really love what they do, but it's so ethically complex and complicated because they have to decide. They have to decide, how we will invest. They are shareholders, you are right, but with this comes a huge responsibility. And we have, those patient groups, in this decision-making body at the ministry. They are doing an amazing job, but it's a tough job for all of them.
And so it is, though. But, making democracy work is hard. It is hard. The thing is that our current batch of politicians thinks this should be easy and soundbitey and cynical. But democracy is hard work. But the good power to your elbow that you're doing that, because that's a model that could be shared. Who'd have thought in Czech Republic you would have that kind of model? Not to be prejudicial or stereotype about it, but fabulous. Fabulous. Go for you that you've got this model. And I'm not sure how many of us knew that was happening. So thank you very much for that. Andrea?
So my wish list for the next mandate, so starting from perhaps the top level to go then down to a more a micro level. So first, we need a strong health mandate, right? We cannot take that for granted. If the Commission has done a lot of work in health in the past 5 years, we need to continue keep health at the top of the agenda. On my side, I think it's very important, or I would like to see a new immunization strategy that helps member states to implement a successful vaccination campaign at national level, including on COVID-19. And then as a company, the ability for us, Novavax, to access the European market and compete on an equal level playing field in the future. We are a company that invested a lot in Europe, and our future here really depends on the ability to compete.
Thank you. Fabiana.
As we said before, health is the most important thing. So my recommendation for the next EU mandate would be not let the expertise that we acquired during the COVID pandemic be lost. We, as institution, have a big responsibility to the citizens and individuals, and we do not have to lost all this expertise that we acquired. And to respond to you before, also the Ministry of Health has adopted a guideline to allow associates from the third sector to participate in the decisional processes at the Ministry of Health. So it's under political evaluation, but we do have it. Finger crossed.
Thank you. Thank you all very much. I'm sorry I can't, I would love to ask each and every one of you, what's your one ask? But we have a space out there, right? And, you know, do what you want, write on it, just make graffiti. I know my colleagues will probably kill me. So there she goes, post-its and pens. I'd much rather you just write on the wall. And it will be a fantastic display of your passion and your primal scream to have something done around health. Because we need a primal scream, don't we, about health. If we hear what's going on, look, we know social progress and scientific progress has meant that we absolutely understand what the #1 killers are. We actually know what to do in terms of prevention, and we know that R&D matters. And actually sharing, exchanging R&D is one of the most powerful things. As you said, Andrea, if we didn't have it 10 years ago, we wouldn't have had the vaccines produced at the rate that we did. Don't lose that sense of momentum and understanding. Thank you all very much. Thank you all very much. This has been great. I've eaten into your coffee break, so forgive me. But, you know, there's still time, I believe. There's enough time for coffee. So I do this, right, which is bugger up the timing. My colleague, who is the director of the health area, looks at me with forensic eyes. If she could stop me, she'd go like that. So why don't you help me and say, what should I tell people? You tell people what they need to do. 12:15, okay. Thank you. Thank you very much. You've been a great audience, but I mean it seriously. Write your notes down there, but if you want a sandbox, let us know. Am I on? Yeah, that's it.
Yeah. This one, the one that was roving in the.
You will test or what? Yeah, no worries. I'll do that live. No worries. Test if the speakers hear us. Okay. And nobody will hear us. And where I can hear? Or in the speakers, or on your computer. Okay. But if you hear on your computer, it's going to feedback. Okay. So if I speak, she will. Hello. Okay.
Hello, Francesca. I'm trying to. Hello. Oh, yeah. Nice to meet you. I'm Igor from events. Yeah, yeah, from events team. So, Friends of Europe. So yes, I need to check you put the background. Okay. The one issue, one thing, I just want to ask you. Nobody goes passing by at the back because background will changing. Yeah. So
Okay, colleagues. That music, the jingle was intended to bring you all back in here as quickly as possible. I hope you had a good lunch. Curtailed somewhat. Sorry about that. But it's an action-packed agenda, as you knew. That's what you signed up for. Lots of discussion in a short period of time. Please. We move into a conversation around digitalization and health. And we have a number of contributions for you to think about how digitalization will impact R&D, investment, or approaches to innovation, etc., and so forth. But also then conclude with a more global view of digitalization. But before we enter that conversation, we have a contribution from a fabulous author. Her name is Francesca Cavallo. And those of you who don't know, she wrote the book Midnight Stories for Rebel Girls, or it might be the other way around. But an international bestseller, translated into like 37 languages. Her book's brilliant. She's brilliant. She's one of our European young leaders. Okay. Sorry, Natalie. I don't understand what that means.
If you would like to see Francesca, who will do a magnificent and brilliant ID sharing, we have reserved seats in front for you. I'm sorry about the misunderstanding. So I'll suggest you sit first here so you can watch Francesca. Thank you.
Okay. So, is Francesca online?
Yes, I'm here. Hello. Hi.
So, there you go. I've been looking for you, Francesca. Lovely to see you. Lovely to see you.
Likewise. Thank you for having me.
No, it's a real pleasure, as always. And you're going to share with us, it's okay to be not okay. Your reflections on that topic. And I know that issues around mental health are very rarely spoken about, but it's one issue that is a global potential killer, but also the precipitator of other ill health conditions. So over to you, my darling.
Thank you, Dharmendra. And good morning, everyone. It's great to be there, albeit virtually. The title of my presentation today is "Are Men Okay?" So I hope I will give you some insight on an angle that doesn't get discussed a lot around mental health. So I will start by giving you 11 facts, 11 points of data that can help guide our time together today. So the first one is that there is a growing longevity gap between men and women. In average, men live 4 to 6 years less than women. The second fact is that the suicide rate in men is 3 times higher than in women. The third fact is that men are 3 times more likely to hit a pedestrian or to be involved and die in a car accident. The fourth fact is that in Italy, 92% of the people who commit homicide are men. And the percentage is not much different in other countries. The fifth fact is that 98.7% of people who rape somebody are men. The sixth fact is that 87% of people who abuse a minor are men. The seventh fact is that 95.7% of the jail population around the world are men. 8, men are less likely to seek help from professional mental health professionals. And 40% of men say that they have never spoken to anybody about their mental health. There is one Italian economist and one French economist who have written a book that is called The Cost of Virility. And their names are Ginevra Bersani Franceschetti and Lucille Pétaven. And they have studied the cost that Italy and France are paying for men's antisocial behavior, and have estimated that it's around 100 billion euros a year, which in Italy is about 5% of our GDP. The 10th fact is that recent studies have confirmed that there are hardly any differences between the male and the female brain. Meaning that the fact that is, often repeated that male's brain is 10% bigger than women, it's not entirely true because the size of a human brain is in proportion with the rest of the body, just like other organs. And a male brain isn't less transplantable than a kidney or a heart, which can be done between male and female bodies. The 11th fact is that when babies are born, only 10% of their neural pathways are shaped, and the rest of it, the remaining 90%, are shaped by learning. So the underlying question to all of this is, what are we teaching men? So this question is particularly important for me because when I wrote Good Night Stories for Rebel Girls, the basic assumption was that girls are not less interested in leadership. They are not less capable leaders. They are not less ambitious. And today we take this for granted because we are standing on the shoulders of decades of feminist research. So when I started having this question asked me over and over again by parents all over the world, the question was, what about boys? And at the beginning, I was like, well, give me a break. Can't we just have one book for us? But then I realized that the people that were asking me, what about boys, were not trying to provoke me, but they were asking a genuine question. So we realized that men are under a tremendous social pressure to perform, and that this pressure is sort of eating away at their mental health. So they are suffering, they are paying a steep price for their political and economic power, and we are still not talking a lot about this. So whereas for girls, we are sort of there is a general consensus that there aren't biological differences that make girls less capable of leading or less ambitious. There is still sort of an underlying belief that when it comes to boys, we're not entirely sure that they are not naturally more aggressive or that they're not naturally less empathetic than girls. But the point is that scientific research shows that boys are not more aggressive than girls, that boys are not less empathetic than girls. The thing is that what we are teaching them, so the neural pathways that we are shaping with the kind of stories that we tell them and the kind of games that we have them play, the kind of toys that we buy for them, are shaping their brains in a way, and social expectations around boyhood and masculinity in general, in ways that are detrimental not only to women, which is an aspect that has been explored more, but also to men themselves. One of the things that I started looking at is, for example, the number of war toys that are marketed with a boy in their image, in the advertising, and it's 90% of war toys are advertised with a boy in the commercial. And over the past decades, for example, Lego sets have shown an increasing number of weapons always in the hands of boys. So there is this problem that we have, that the storytelling around boyhood and masculinity promotes a sort of a split in the male psyche, and it convinces them, and just think about characters like 007 or all the superheroes, Spider-Man, Superman, that only the most performative side of men is what needs to be shown out in the public, but all of the, the relationship between boys and their internal emotional life is to be kept hidden, sometimes even from the people that are the closest. So this creates a culture of isolation that makes it incredibly harder for men to seek help for their mental health. And we are all paying the price for this. And if we think about the male heroes that shaped the understanding of masculinity in Western culture, from Achilles, who gets killed for his only vulnerable spot in his entire body, which is his heel, or to other most modern characters, we have this problem that we are keeping on promoting this narrative of that the absence of vulnerability is what makes men strong, and this is an incredible hazard in terms of like public health, and it creates also a very problematic understanding of domestic violence, because what we are doing when we look at measures to fight domestic violence, we are focusing mainly on women, and it's like we are distributing umbrellas and we're not looking at the roof that is leaking, and we're not doing enough to prevent domestic violence from occurring. So what I want to leave you with today is this idea that we should start looking at violence as a public health matter rather than a security matter, because the vast majority of violence occurs from individuals who are incapable of engaging in social and constructive behavior. I believe that is my time, Dharmendra.
It is. It is. We could listen to you forever. You don't. You are a storyteller extraordinaire. And what I was thinking, I love you dearly, is that I wonder how many men in the early turn of the last century would have made a passionate plea, as you just have, about the plight of women. Not having the vote, not having stable livelihoods, and having their mental health corrupted by a system that was dominated the way it has been, continues to a certain extent. Thank you for bringing that into this conversation, really. There's an author called Jeffrey Weeks who once said, and this is kind of something I must have read like decades ago, he said, masculinity is so all-pervasive, it's almost like oxygen. We breathe it in all the time. And you brought the power of that metaphor directly into this room. Thank you. And I hope that you, bring a book about it. I'm sure you're going to write a book for young men and teenage boys. And perhaps, I'm not sure how men in this room will react to what you've said, but it's a message that's come of its time. And it's power to your elbow that you, as a successful writer, a woman, has been able to bring that to this table and this discussion. We love you. Thank you. Take care.
Thank you. Thank you.
Thank you.
Bye.
Okay. Panelists, please. We thought it might kind of make it more interesting to have an author, spice things up in the middle of our summit. I hope you liked it. And also, she's fabulous. But it changes things up, and we're constantly striving to think of ways in which this notion of summitry, that everyone getting together over a day or half a day, how do we kind of make it a bit more interactive, make it more thoughtful, more emotionally balanced and weighted. So more of that will come in the future. But that's what we're hoping to do. So we now move into the discussion I was mentioning earlier about the impact, importance, viability, and the future of digitalization in healthcare systems, and what it's likely to do and what it should do, and what are the kind of lessons we can learn from our experience up to now. But again, like in the other panel that we had this morning, is always targeting what should the new EU mandate do in relation to digitalization of health and healthcare systems. So I'm going to first turn to Maya. Maya, thank you for being with us. Now, you're intimately involved in the issue around European health data space. If I get that right, I always get it wrong. What's the potential of that to help us move things forward, but also really, I suppose, help us innovate as well in the system? Over to you.
Thank you very much. And thank you to Friends of Europe for inviting me and also for having this great introduction. I think that I wanted to also just use this opportunity to say that today, in another building quite close to here, there is a big conference on mental health that the European Commission has organized in response to the comprehensive approach to mental health, which we adopted earlier this year. I think the pandemic has really brought to the fore the importance of really addressing mental health, physical health, environmental health, all in one way. And so I hope that today's meeting will address that. And accompanying that was a Eurobarometer that was published yesterday that showed that nearly 50% of people surveyed had experienced anxiety and depression. So I think the first step is destigmatizing mental health issues, that we all feel them at one time or the other. And just like you speak to your colleagues about having a headache, it should be the same, that you could say, I'm feeling very anxious today, or I don't know why I'm depressed. But let's talk about digitalization. You could say that they're quite linked in a way, because what happened to us 3 years ago, our life as we knew it changed automatically, overnight. And this involved also the way we reached out for health. So many things happened in the last 3 years. The effects of COVID, I think we still haven't actually realized or experienced the full effect that COVID has had on every facet of our lives. But one area for sure is on health and health systems. Globally, health became the top priority for all world leaders. As I used to say, epidemiologists became the new rock stars. We were all glued to our TV, looking at figures, discussing our numbers. This had never happened before. And what we see in health systems in front of the TV, all of us saw, it was all focused on the hospitals. We saw health workforce. We saw that we didn't have enough health workforce, or the ones that we did have were not trained to deal with the ICU aspects. We also saw something dramatic happen in terms of digital health. The digitalization of health systems, many of you here, I'm sure, have been working on it for years and years. We had the tools available, but we didn't deploy them. And so what COVID did was actually a kind of natural experiment where overnight it was, to coin the Oscar film, everything, everywhere, all at once. And now we're in a situation where this is pervaded. Some countries are continuing to build on the digital health and digitalization. Other countries have rowed back. Other countries didn't even start. So we're in a very fragmented environment at the moment with digital health. I would say one of the most important things now is to really put some sort of evaluation, monitoring in place. We don't have good indicators. And this now brings me to the challenges that we see ahead of ourselves, that we're very worried that we are going to create a digital divide where people who have found access to digital health services will continue using them, but we have to be very, very mindful of swathes of people who do not have the digital health literacy and skills that are needed. And I was in WHO Europe last week, and the colleague there said that for him, this is one of the key issues now, is digital health literacy. Otherwise, we are going to create a two-tier health system. Those of us who do it all via computers will be able to get appointments quicker, maybe, and others that are relying on phoning or filling in forms. So I think that the timing to have a discussion about where we are, what are our values that will underpin a good system. And I think it was very good that you asked. It's not if, it's how, because I think the if is already there. We need digital health tools. We need digital health tools not only for health delivery, but also in public health. And I'm a big proponent of public health. I think one of the things that the pandemic showed was that most countries worldwide, I would say, have underinvested in public health, surveillance, population health, just understanding what's going on in the population. And so the European health data space is basically a way to try to put some order and to create a framework for information and data to travel. The first arm of it is about the individual, because we feel that for data, as I said, the digital health skills that are needed, it's to provide every individual in the EU with their own medical record, and the fact that they can carry this medical record around with them, so that if they need to see a doctor in a different country, they will be able to share their medical record with the doctor and it will be automatically translated. I think that is an audacious and bold plan in itself. Then we look at all of the data that's out there and how can we make sure that it's used for good and that we actually unleash and tap into the huge potential that's out there. I think the bottom line is this is happening anyway. People are finding the data wherever they can in a very mismatched, ad hoc way. So what the European Health Data Space is doing is it's creating a system in place for there to be a very easy, smooth, implementable way to find this data for researchers, for policymakers. So it's very exciting. I'm very happy that MEP Sokol is here because he has a big part to play in this. And I think that for innovation, in terms of all of you who are looking there, I think it'll be huge because you will be able to have access to a lot of untapped data. You'll be able to have data from across different countries. But again, I think I would like to reiterate that the first and foremost is about giving individual people and empowering them with digital health, because only by building that trust that they see data being used for good will we be able to move forward. Thank you.
Maya, thank you. That was hopeful and optimistic. It's great. It's like refreshing that you're not saying that, you know, it's all council member states and the council and we can't really get this data thing sorted. It's great that you're looking at it from, and you're positive and you've filled us with hope that, you know, a European health passport might be eventually possible rather than in a century, but very soon, I hope. So good to hear that. I'll bring you in on other questions in a moment, but thank you for setting out that broader framework, and that's about the potential and possibilities rather than the impossibility of using data. I'm going to move to Ridwan. Ridwan, thank you for being with us. You've been in the field, in terms of medical practitioner or research, and now working for BMS. Share with us the impact of digitalization on cancer detection, care, and prevention.
Thank you so much for the question, Dharmendra. And also thank you to the Friends of Cancer for organizing this event and giving me the opportunity to present here today on this panel. So let me provide some context before getting into the topic. Around 18 million patients are diagnosed annually across the globe with cancer. In 2020, 10 million cancer deaths were recorded across the globe. And if you look at the situation in Europe, although Europe accounts for 1/10 of the world population, it actually, in Europe, we actually have 25% of cancer cases. So that in itself speaks to the issue of cancer in Europe. In terms of the EU Beating Cancer plan, it is estimated that should this trend continue, cancer will be the leading cause of death in Europe within the next 10 years. Although innovation has had a positive impact, newer treatments are much needed to actually deal with situations where patients either do not respond or fail to respond to the cancer treatment. Scientists are working relentlessly to look for new targets and new therapies to actually bring both treatments for hematological and solid tumors to be available to patients across the globe and including Europe. At BMS, we are committed to cutting-edge research to actually bring more medicines to more patients faster, leveraging 3 key platforms: immuno-oncology, cell therapy, and protein degradation. Strong collaboration is required to actually make this happen, which will include clinical researchers, biological researchers, as well as computational research teams. From our perspective, the power of understanding underlying causal biology is being enabled and enhanced by digital capabilities and computational power. In addition to this, we actually see computational power leading to increased manufacturing and scaling up of the production of treatments such as cell therapy, which is used today for treatment of multiple myeloma, lymphoma, and in the future for other cancers. Moving on from the impact of digitization on drug development to bring these treatments to cancer patients, what about the impact of digitization on the healthcare infrastructure? First and foremost, optimizing access to data is critical to be able to better understand the treatment journey of every cancer patient in terms of when the disease starts, how it progresses, how it can be prevented, and how it can be actually better and earlier detected. So that said, health data is increasing both in volume and in complexity. Very much different to when I started off as a clinician treating a first breast cancer patient many years ago. This does then bring to the point, I think linked to what my colleague Maya on the panel said, that the importance of having data records that are electronic and available and accessible to patients. So starting off, electronic health records, it's critical for health systems to actually move fully to electronic health records. And where these health records are in place, it will be critical for the data to actually be stored in the cloud, basically, rather than being kept on servers. Integration of health records with smartphone technology, as well as fourth industrial revolution technologies, IoT, will also allow additional data points to make better treatment decisions for cancer patients. In terms of cancer care, looking at remote patient monitoring, for example, if a patient had to be treated within their country, even outside of the country, the availability of wearable tools, as well as patient-reported outcomes that are captured online, allows for continuity of cancer care after the acute treatment takes place in an institution. I want to also touch on the fact that COVID actually did expedite, as we heard earlier on, telehealth, where expert online consultations allows for bridging the cancer gap. Bridging the cancer gap for those unrepresented groups, the elderly, socially disadvantaged, as well as those that are living in remote locations across Europe. Linked to this, teleradiology and telepathology also will allow for remote assessment and review of pathology samples as well as scans from patients, X-rays, CT scans, PET scans, to allow faster turnaround time and, again, quicker movement towards treatment of cancer patients. Virtual tumor boards also allow an opportunity for multiple experts to come together to discuss treatment options and to then ensure the treatment plan happens locally. So there are a number of avenues in which healthcare systems can actually move towards optimizing their infrastructure. It does call for investment. It does call for adoption of these tools. I want to move quickly to the impact and potential impact of AI specifically on the early detection and treatment of cancer patients. AI, as many of you in the room know, is a machine's ability to learn and recognize patterns and basically provide better insight into cancer, to provide better insight into decision-making in general. I'm going to quote a different book to the one that was mentioned early on. Professor Kahneman is a renowned expert in decision-making, and I recently read his book called Noise. In summary, it talks about the variability in judgment about the same problem. It can happen in any sector, the legal sector, medical sector, etc. So in my opinion, leveraging AI will actually reduce the noise and variability in terms of early detection and even for better treatment decisions for cancer patients. We are already seeing that AI is reshaping early detection and treatment of cancer in Europe. To give you some examples, the AI-based risk profiling is leading to better diagnosis and better decision-making related to oral cancer, cervical cancer, as well as breast cancer. Quoting yesterday's newspaper, where in Northern Ireland, almost 20,000 cancer patients, almost 20,000 patients will have to have their pap tests rechecked. And that is basically because of understaffing, poor training, and underperformance of staff within these institutions. And thirdly, very poor quality checks. This is, again, an additional opportunity where AI could actually reduce such types of situations from occurring. AI-based imaging analysis can also help us to earlier detect from chest X-rays lung cancer, as many of you will already know. In terms of improving treatment decisions for patients with cancer, this requires large data sets. And I want to mention that many many projects are ongoing. I want to call out one project that BMS is involved in, and this is the Harmony project, which is run by the Initiative for by the IHI, and this initiative is actually looking at leveraging, collecting, and analyzing large data sets to optimize the outcomes of patients with blood cancers such as multiple myeloma. So a lot of progress has been made, a lot of opportunity, but it does still require heavy investment, close partnership, including public-private partnership, as well as supportive legislation to make this happen. And I also welcome the point about the European health data space that will allow for patients to have more control over the data, to enable more vaccines, diagnostics, and treatments to become available for cancer patients.
Excellent, Ridwan, thank you very much. That was a tour de force. You point to the issue that actually, when you gave the examples of how it can fundamentally transform, AI can fundamentally transform detection, care, and prevention issues. There's an opportunity here that, in terms of the new mandate, is that how do you fundamentally shift thinking about AI, not simply around jobs being lost and privacy and other matters, but something as a force for good for the well-being of society. And that, I think we need to make that argument more and better, because at the moment it's seen as a very evil god that's going to take over our lives. Thank you. I'll come back to you in a moment. I want to shift straight to Nazreen. Thank you so much for being with us as well. Good to have you here all the way from the Netherlands. It's not too far, but it's great to have you here. Digitalisation of oncological care. What's the impact of that? So you have the whole kind of movement to the kind of things that Ridwan spoke about. What impact does that have on research, if at all, but also care?
Yes, thank you so much for the introduction, and also thank you for the invitation to speak here. I'm very happy to be here. I think a lot has been said already by Ridwan when it comes to the potential of any of these digitalizations for oncological care. And we've discussed the potential also of the European health data space for patients to be more in control of their own data. But I want to highlight specifically digitalization of more basic electronic medical records and how we can extract the data to use for research to really progress, make a large progression, catalyze research, and move more towards personalized treatment options and prevention options for cancer. So the secondary aspects of the European health data space. There are multiple reasons why researchers cannot access data from medical records. Every member state also has different issues with this regard. But one of the aspect is definitely legislation. So there is a very big need for clear legislation with regards to secondary use. Otherwise, we risk member states fitting it in differently altogether. So there's a big need for that. But at the same time, there's also many technical issues with regards to data and us not being able to use it for research. In the Netherlands, for example, we have a lot of different software applications that are being used in healthcare facilities. Even within facilities, multiple applications are used, and for now it's mostly typing from one system to another on a daily basis. I think one doctor once told me that for a basic breast cancer patient, it's at least 40 times typing over from professional, and this is still, it's the status quo of today, unfortunately, and not only is this extremely inefficient, but it's also it gives us an insight in what needs to be connected. Do we ever want to get a hold of that data? So there is a big technical issue, interoperability issue that we need to solve before we will be able to access this data and the potential of it. And I'm a strong believer of that it has extremely high potential to change the way we look at health. And the earlier session, I think we already tapped on a little bit on what we can, or that we must actually shift more towards prevention. I was at the Radical Health Festival in Finland earlier this year, and you cannot pin me down on the numbers, but I remembered from one of the presentations that around 80%, give or take, of our health is determined by our social factors, the crib that we are born into, our environment and socioeconomical status. And the not even 20% that is left is influenced by the healthcare that we actually get from the medical professionals. So we are focusing our money on influencing our health on the medical care aspect, while we can influence way more if we look at the other factors as well. And we need all the data of people to be able to tap in on that potential. And maybe to wrap up my talk and go to the next speaker, I think that specifically for oncology, it would be very interesting to look at. It would be very helpful if we can use other data to develop more personalized treatment options and prevention options, as I mentioned earlier, but specifically AI-powered precision medicine. I think it will really change the way that we treat cancer. To give an example, if we have more data accessible and we use AI to analyze it, we might identify more and more specific mutations in cancer cells that we could act upon. And this may also provide prospects to cancer types to people that now have been diagnosed with cancer types that are very difficult to treat, let alone for rare cancers. So we really need these kinds of innovations to make the difference. As Redouan really nicely portrayed how we're doing when it comes to cancer, it's almost the #1 leading cause in Europe, and it is in many European countries already. So we really depend on research to better our odds. Thank you.
Najin, thank you so much. And you know, again, you demonstrate the power of AI. It seems like our system, our healthcare system, if we can call it that, is analog, waiting to have it pulled apart for an AI opportunity. It's really quite startling. How many healthcare professionals are there in this room? Hands up. Interesting. I mean, if you're working in the system, aren't you struck by how could politicians and whoever the administrators are create the kind of system that we have, where you've got, at least if you go to A&E or other parts of hospitals, there are 4 or 5 different applications, as you say, or even data, let's say customer relationship management, if they adopted for hospitals, that if you go from A&E to a ward, it's 2 different systems. When you're being actually discharged, it's a different system. It makes no sense. It makes no sense. So any of you who are from the profession, can you shed any light on in terms of how we might change that at all? Yeah, I thought so. Go on, you put your hand. Please.
Hello.
Hi, please introduce yourself.
I'm Mihai Toderica from National Administration Association, Romania. I think one solution should be that we would have one healthcare system, only one, for Europe and European citizens. This is our opinion, and this is possible. Last year, everyone said, no, this is not possible here at Friends of Europe. But we should look at common agriculture policies. They work very fine. Very fine. This is what we should do. It's our opinion. Also, I think we should have only or just a health European agency, not dealing also with space. And also different agencies have health competence in Europe. So also just one health agency.
Simple but radical. Thank you. Absolutely. And common sense. When you think about the economies of scale that can be achieved on a European level for a digital platform for sharing data, diagnostics, AI, it's phenomenal. But that's the kind of radical thinking. If you were here in the earlier session, what we need is, as we said, that we would want to create a sandbox for different ideas. You're the kind of person we need in that sandbox with others that can think radically and progressively. Thank you very much for responding. Julia, want to come back? Go on.
Yeah, I just wanted to add that this is a very popular view that we hear from healthcare professionals, but not so much from policy advisors. So this is really a translation gap. But
it's not a translation gap. It's just a blind spot in politics. Yeah.
But it's definitely, we hear this all the time from healthcare professionals in the rare occasions that they are present, because it's very difficult for them to be present for all these sessions. So we should listen more to them.
Absolutely. Couldn't agree with you more. On the note of politicians, Tomislav, thank you for joining us. And I'm not going to put all the pressure on you, don't worry. It's more a case of, as Maya said, you've been someone who's supported the European Health Data Space Initiative and think it's important. Can you share with us how this initiative will either serve as a springboard or a launching pad for, or a pathway to better sharing of data, more intelligent use of data, and crack the nut of interoperability?
Yeah, thank you very much. Thank you for inviting me. I was a bit late because this is actually my third health-related event today. So, and one of them was on the HDS. So definitely a big topic now. So first, I think we just to present the framework. So we have one framework for the so-called primary use of data, and then for the secondary use of data. So primary use of data is use of data by the healthcare providers. So the whole idea is that we have one electronic health record format across Europe, which can be then shared and exchanged across borders. So for instance, if I'm traveling from my country to Belgium or go for a business trip to Germany, I have to see a doctor, that this doctor can access my health data, my electronic health records right away. Prescribe me with medicines, know if I'm allergic to something, if I have underlying conditions, if I have some chronic disease, etc. So that the diagnostics and treatment can be much faster, much more efficient. And so that's the idea. So interoperability on that level is that we have common format, common exchange format, and that this can be used by healthcare professionals that I go to anywhere in the EU, which is all important not just within the EU, but also within the same countries, because in many cases in same countries, you do not have this interoperability of data. For instance, in federal countries like Germany, it's sometimes problematic to have data exchange from one healthcare provider in one federal state to the other.
Yeah.
So this should be resolved by this. So this is the whole idea. And also for the patients, if the patients do not want part of their data to be accessed by some professional, they can restrict it. For instance, if they have some mental health condition or something like that, and they don't want every healthcare professional who treats them to see it, they can limit the access. So the whole idea here is to actually have this one common European format, that this can be used in accessing healthcare, and the patients have control over that data. And they themselves also will be able to access this data, see this data, etc., etc. Feed the data into systems, for instance, for wellness apps, etc. The second, and everybody agrees on that. So on that, definitely there is no big political issues, some technical things about the assessment of the technical issues, etc. But this is not a big problem. Secondary use is the big elephant in the room, let's say. So the whole idea of secondary use, how this will work. So healthcare providers and those who have data, like for instance, big university hospitals, would have to catalog this data. So create catalogs of all of these data sets. And then if somebody wants to access this, they could see if there are some data sets that could be interesting for them, like for instance, pharma company or university, etc. Then they send a request to health data access bodies, public bodies within the member states, to give them data permit. And if this data permit is given, and this can only be given for if they want to access data for some specific purposes like research, innovation, etc., things like that, policy making by public institutions, etc. If this data permit is given, then they can access this anonymized or pseudonymized data in a secured environment. So nobody will be able to take away, download this data, take it with them, but actually to access this in secure environment and use it in the way they want. So this is how this should work. Of course, the big thing which is controversial on secondary use of data is who can use this data for which purposes and what should be the patient's role there. And of course, in the parliament, especially in the left side of the parliament, people do not like the industry in general very much. So they are always, and they want to score political points, and it's easy to score political points in the pre-election year by attacking the industry, especially some industries, which are sometimes easy targets for them at least. So this was the big fight. So whether everybody should be able to access this data, not just public universities, but also pharma companies, under what conditions? Because some said that Facebook or Google will be able to access this data for social profiling, whatever, which is not the case. But we then narrowed this down, so we defined the purposes for which data can be used in a much narrower way, and also the role of the patients. Because in the original Commission proposal, the patients had no say in the sense that they can refuse to give access to their data for secondary use. And we knew that this is politically impossible to go to the Parliament, that the Parliament will definitely want to have more role for the patients, and this is the reason why I, as the rapporteur for this file, proposed the so-called opt-out. So the opt-out, the idea that those patients who do not want their data to be part of data sets that are used for research, innovation, etc., can decide like that. So the idea is to give them the power to decide. But on the other hand, it was important to also strike a balance between this right of patients on one side, and on the other side, the need to actually have unbiased and representative data sets. And to do that, opt-out is definitely as far as you can go in terms of data protection. If you went for an opt-in or a consent-based system, whereby every patient would have to give consent each time when data set, where his data is used, then this would not work. Then this data, we would not have enough data, it would be useless. So this is why we went for this opt-out. We narrowed down the definition of purposes for which data can be used so that it cannot be misused. We added some additional safeguards in terms of data protection, privacy protection. We put there a special provision that this data can never be used to re-identify the patient. And by doing that, we believe that we struck the right balance between the need to use the data on one side and also the need to protect privacy on the other. But the whole idea, if we want this to be useful, and this goes back to your actual question, if we want to have large data sets that we can use, that can be unbiased, representative, that can be actually useful to develop new medicines, etc., then definitely we need to have enough of this data, and then opt-in or consent-based system is not an option. And this is the most controversial part, because we are having discussions in the Parliament. It seems that we have the majority now on the general opt-out, maybe with some exceptions, but definitely I think we are very close to finishing this. Of course, the crucial thing after the Parliament's position is negotiations with the Council, and there two important things will be important. First will be money. They will ask for more money from EU budget, and I think they're right. We'll also ask for more money, because in the what Commission proposes is definitely not enough. So we think we need more funding from EU level, and in the next revision of the multi-annual financial framework, we'll propose definitely more money for the implementation of this, especially since the situation in member states is so different. Some member states are very well advanced in terms of digitalization, etc., like Finland, even my country, Croatia, but some are definitely...
So it would be to create infrastructure to support this new approach. Is that
infrastructure, training. Also, I think what is important is also to provide incentives for healthcare professionals to feed data into the system, because healthcare professionals that I talk to, who are university professors, who work at university hospitals, who do research, for them this is great. Yeah, they are very, very enthusiastic. But people, for instance, who work in primary care only see this as another additional burden upon them. So we have to provide really incentives to actually have everybody accepting this, because without this, implementation would not work.
That's great, thank you. If I can ask you, well, I will ask you, what are you putting forward, I mean, you're probably being reached out to, or you're probably reaching out to the Secretary General's office or those who are creating the policy book for the new mandate, right? If you're prepared to share with us, what would you want? What do you want to see happening in terms of health as a policy objective in the new EU mandate?
In the next mandate, dealing with digitalization or in general?
General. What would you want?
Okay, so
we're going to tweet this, by the way.
Okay, so we'll need to finish the pharma package.
Yeah.
We'll need to finish the pharma package. So I'm also shadow rapporteur on the regulation. That's one of the two pieces of legislation. We will not finish before elections. That's certain. So to finish, to pick up on that work right after the elections, that's important. Also because of streamlining, incentivizing research, innovation, strengthening European strategic autonomy on one side, but also facilitating equal access to medicines on the other. Will definitely, EPP, I expect, will have a very important part of its electoral program, the new cardiovascular strategy, similar as Europe's Beating Cancer Plan, because cardiovascular diseases are the #1 killer. So even bigger killer than cancer. So we believe that we need definitely much stronger rules, more systematic rules on that it's not enough to have everything under Healthier Together initiative, that we need something more specific. I think we should revise the Transparency Directive, even though member states always oppose that. But this is definitely something that we'll have to reopen again. So the Transparency Directive, which regulates conditions under which reimbursement of medicines decisions are made on national level. This is a national competence, so member states decide on what to reimburse, but the procedures are really very different in different member states. There are different criteria. In many member states, like in my country, there are no clear rules and procedures and transparent procedures on how this is done. So to also open this topic will be important, and also the revision of cross-border healthcare directives. So cross-border healthcare directive definitely doesn't work. It's not used to its full extent. So I believe that we need much clearer and much simpler rules on reimbursement of cross-border healthcare. So when you cannot get healthcare in your own country, that you can go to other member state. I mean, this is so complicated that you have to be a healthcare lawyer and expert to understand how all of this should work. So we need much simpler rules on them, much easier procedures. We also need to invest more into European reference networks, which can really be used to share experience and also to get their second opinion on what is the best possible treatment in Europe. And also definitely the next EU for Health program, the next funding program will definitely have to be much stronger in terms of funding than what we have now. This program now, for this 7-year period, is definitely an improvement over what we had before, because it's 12 times bigger. So in 2014 to 2020, we have 450 million euros, and we have 5.3 billion, but it's still not enough. I mean, we have now Europe's Beating Cancer Plan, 4 billion euros implementation. We have the mental health new communication strategy, 1.25 billion euros. A lot of things will have the European health data space, so definitely we'll need to provide much stronger and much more permanent source of funding from EU level than we have now. So we can do, but what we can do all of this without actually changing the treaties and competences, etc. So we can do all of these things within the competences that we have now. We just need the political will to do it.
Excellent, thank you very much. I was going to say, you went there because I was going to say, actually, does this need treaty change? It doesn't. We saw it during COVID. Europe can do what it wants in times of crisis and actually do the most impactful things during the period of COVID. So treaty change is not the issue. But your list, it feels like, and it's a good list. I just wanted to push you to say, actually, where does that list fit into a big policy coherent message? But that's something I'll come back to as we come to
if I just want to ask, I think one underlying principle should be that all EU citizens should have access to equal standard of healthcare, because this is actually what it all comes down to.
Yes.
Because differences in terms of access, in terms of standard, in terms of equipment, in terms of access to data, etc., the level of digitalization, this is so different. There are so big differences that I think all of these policies actually can fit to this one idea that all EU citizens should have right and access to equal treatment.
That should be a good policy takeaway. Thank you very much. Ricardo, Again, so Ricardo and when you heard Francesca, they were both one of our European leaders, as is Nina. So we've got a smattering of European leaders during this summit. So Ricardo has been a European leader for some time, predates my time, I have to say. Not because of age, I'm much older than him, but I mean in terms of my involvement in Europe, Friends of Europe has been relatively recent. But Ricardo, I don't know why I went there, just make sure that we brand European young leaders. You've been an MP, you've worked in the national government, you've kind of your expertise in health, you're now working globally on AI and everything, right? So you're bringing, you should be a future commissioner on health potentially. But given what we're hearing about AI, and we know, the reality is, you don't have to look very far. If you just go literally a mile and a half away from this building, you will see abject poverty, how the phone, it becomes a social tool, but the literacy and its capability to transform life is very limited. So we know digital divides are huge. My question is big for you, because you can handle that, because I want you to, roam large, if you like, from a global perspective on digitalization. And what can we kind of learn about, let's say Silicon Valley has been a kind of a real example of what went wrong. We have a different moment in time where AI can burst onto this stage in a way that's quite transformative. What can we learn from that, rather than making AI a force for good rather than a force for bad? It's a lot there, I know.
It is a charged question, but thanks, Dharmendra. And you presented me as a European leader. I used to be part of the European Young Leaders, but I guess you've dropped the young since I've been here for so long. And good morning. Good morning. Good morning. Oh, thank you. Okay. So we're going to talk about artificial intelligence. Let's keep that human connection there. And that's a big issue. How do we keep the human compassionate centeredness within our activities in health and in the application of technology in general? But trying to address your question, I'm going to go from a bird's eye view and then deep dive, if you allow me. First of all, just to say, Francesca at the beginning, I think, was a great eye-opener on mental health, as Maya was mentioning. My first years were as a doctor working in infectious diseases. A lot of people striven with poverty, people dealing with drug problems, a lot of sex workers. And I have to say, what she said about us giving away umbrellas and not fixing the roof is absolutely true. And I hope her message resonates also with the next commission when it comes to mental health and going to those underlying causes. But going back to that bird-eye view, a couple of weeks ago, we had the United Nations General Assembly, where the Secretary General said that the world has approved the Sustainable Development Goals that we need to achieve by 2030. It is 2023, we approved them in 2015, and we have only accomplished 15%. 50% of the time has passed, we have achieved 15%. If our leaders were CEOs in a company, they would have all been fired because they have not been able to reach the KPIs that they have signed on to their shareholders, which are the citizens. At the beginning, everyone said, state budgets are not enough. We need the private sectors to step in. Nobody really paid much attention. We created UN Compact and a whole bunch of initiatives to bring the private sector. Now we're hearing, we need that private money pumping in. I do hope that the lack of results makes everyone understand around the table, despite, as you were saying, how easy it is to hit the industry, that we need to work together and to do it in a transparent way. And yes, Dharmendra, we have a tremendous digital divide. Maya also addressed this issue. And it's a bit shocking when you look at the data. The further away people live from a hospital, the higher the probability they do not have a phone or they do not have access to the internet. So many of the technologists that are promising that technology will solve all of the problems for those that do not have access to health, well, it's actually not true, because we're not solving those infrastructural problems that we need to address beyond the issues of digital literacy and so forth. So all of that needs to be addressed simultaneously. Deep diving now into health. Last night we had a discussion, and Nazreen was just mentioning how basically we're spending so much money on something that actually doesn't fix health. We're spending 80%, in many cases more than 95% of our resources to react to disease. That is the absolute truth. And that's why every year, in every member state, ministers of health are saying we are spending the most we've ever spent in our history in healthcare, and the results are worse. And if you think about it, more money, more resources, and worse results, there's a serious management problem underlying it. And the management problem there is that we are focusing on the wrong KPIs, the wrong outcomes, the wrong incentives. So what examples can we look on as positive? I'll share two quickly. From my home country in Portugal, in the primary care level, we have what we call classical primary care clinics, where family doctors and nurses get a salary no matter what they do. Then we have another type, which we call family health units, Model A, where we measure results, health outcomes. And in the family health units, Model B, in which we measure, and we actually pay the healthcare workers and the administrative staff if they reach the goals that were previously agreed upon. So 2 examples, diabetes and hypertension. We were talking about cardiovascular disease as the main cause of death. When we started measuring results, we doubled the number of controlled hypertensive and diabetic patients without even more money, just by measuring results and by comparing results per doctor, per healthcare professional, putting that necessity of oversight in terms of the work that everyone is doing and a positive comparison between colleagues to push everyone in the same direction. When in the Model B we put a financial incentive associated to that, we actually saw an additional 20% of rise. So today in Portugal we have basically 3 systems. So if you end up in a classical model where people get a salary no matter what they do, about 30% of the diabetic patients are controlled. If you go to a place where there's financial incentives and you're measuring the results, it can go to up to 80 to 90% of controlled diabetic patients. Outcomes matter, and paying for incentives matter. That, I think, is critical to have as an underlying thought, because that takes us then to the power of digital. For this to become a tool, using incentives, using those carrots to move the direction towards health, well-being, quality of life, we need that power of digital, of data collection, of digital processing. And I would argue artificial intelligence as a leveraging force to allow us to provoke this transformation in health systems, to be able to look at health indicators, not just within the system, not just reacting to disease, but within the communities. We need to lower the burden of disease. We need to make sure that less people go to hospitals. We need to transform our systems to be less dependent on hospitals and to keep people more at home, to move towards a hybrid model which technology and artificial intelligence can actually allow us. It's hard to convince politicians. I was 4 terms in Parliament. I know how it's easier to open a new, shiny hospital and be on the front page of the newspaper 2 months before the election than to say, I'm going to keep people at home and healthy. It's a hard sell. That's why citizens need to stand up. It has to be a cause from the grassroots, I would say. But we need to make sure that artificial intelligence, having that leverage capacity, is actually used and embraced. There's a lot of fear right now among citizens, among policymakers, and a lot of uncertainty because we're dealing with technologies many do not even know. Even within the regulatory agencies, there's a lot of uncertainty. Health AI, the nonprofit foundation that I run in Geneva, is aiming towards building that capacity in the regulatory agencies around the world and building a network, a regulatory network, so that if something goes wrong with the technology somewhere, an early warning system kicks in. So a flag is put up so everyone is warned. We believe this is critical, but also the volume sharing of the work to validate all of these AI tools with the number of tools that are coming to the market. If we do not do this in a collective network at a global level, we will fail. And I believe that this is critical for us to address. And healthcare actually has an advantage in this space, because when we look back to medicines, in the 1950s, there was a drug called thalidomide, many of you know, antiemetic, an anti-vomiting drug given to especially high upper class women who were pregnant to avoid them vomiting, which led, due to the lack of regulation, to more than 10,000 babies being born with birth defects and many more dying. That led actually to a transformation globally. The need for regulation health technology assessment started there. We need to do the same before we have the harm in society with artificial intelligence. The principle that we learned the first day at medical school, first do no harm, is not avoid risk at all costs.
Exactly.
First do no harm means let's mitigate risk as much as we can, and then ponder if the benefits outweigh the risks. And if those benefits are sufficiently strong and the risk sufficiently low, then it makes sense to put it into the market. But you have to have that framework, that regulatory framework, using international standards defined by WHO and others, that can ensure the safety, effectiveness, and quality of the tools, but also creating the carrot, the financial incentive for companies to want to open their black boxes. And the truth is, if we create this regulatory environment, we create a pathway through which companies can then have access to reimbursement. So there's a financial incentive there to get them to participate in the process. I'll just end by saying the following. Be it through artificial intelligence or digital technologies, or just redefining our indicators. The Commission has this role, has the money to align the carrots, the incentives with the KPIs. And when defining what outcomes we want to aim for, be sure that the person at the table that actually has the power to make that decision are the patients and the citizens. It's not just creating a council to hear patients, it's giving them the power to decide, because nobody knows more about their own disease than the person living with it. And defining outcomes needs to be defined from the patient's perspective. The fact that we've done it always the other way around has led to this rise of burden of disease that we need to counter very quickly in a very quickly aging Europe across the board. Thank you.
Thank you. He's so naturally a politician, isn't he? He speaks so well. You've got to go back to politics and change this game. You really do. But, you know, wonderful, wonderful kind of, and you need that kind of both inspiration, but also being able to problem solve and look back at history and what are the tipping points that moved us into social progressive developments on health. We seem to have lost that ability, it feels like, that in the past 5 years, even in the context of COVID, we can't seem to really, as we heard earlier in the earlier session, that we had the Minister for Health, you may have heard from the Republic of Czech, and was saying that our conversation amongst health ministers is about primary care and the shortages of penicillin. I mean, go figure, in the 21st century, when you're thinking about what you're saying, it is a disaster. And how is it we got to this place? It's remarkable, but it's clearly politicians taking their eye off the ball and not treating health as an economic good, as well as a social good. Absolutely. So thank you for bringing all that together in the way that you have. And that message, so combining Tomislav's message about what the next mandate should do is have that principle of everyone should have equal access, but also quality of healthcare access. And your point about no harm, it would be great if that was a brand for the EU's new mandate, do no harm. Wouldn't that be great as an anchor and a Northern Star? But I know that Ridwan, you need to go. So before because I'm going to carry on for a little bit, and if I can crave your indulgence, just for 5 minutes. But if you need to go, which I know you do, is there any last point you want to make about what's your message to the new EU mandate?
So I'll kind of summarize my message looking at it from two perspectives. Number one, looking at it from the patient perspective. I think we need to ensure patients are empowered and can basically have access over their data and be more aware, especially cancer patients, of the treatment opportunities that are available for them and the screening opportunities. The second aspect, which I think is super important, is to ensure that the physicians have access to innovative treatments, and secondly, to ensure physicians also have at their disposal, I know it calls for an investment, but physicians need to have at their disposal the latest tools to ensure that they are making more accurate decisions in terms of optimizing the outcomes for their cancer patients.
Indeed, but and also not to be overworked and have their mental health not destroyed on the ward. So I think those are two other important elements I hope you'd agree that doctors desperately need at the moment. Thank you very much for joining us.
Thank you.
Safe flight. Thank you. Maya, I wanted to ask you, because I want everyone to have that 60 seconds, of what do you want? You're a civil servant. So I know the bounds of what you can say or not. But in those bounds, what can you share with us as to what you'd like to see happening or what you think is likely to happen in the new EU mandate on the health agenda?
Yeah. I think one thing for sure is that what the last few years have shown us is that we can't be certain of anything. I think what the last few years have shown us is that we need to be opportunistic in health. I think we need to be pragmatic and realistic, but I think we've learned a lot. We've realized that we can, by working together and creating new partnerships, really do a lot that was unimaginable. So for me, the next mandate, I think, will be about different types of partnerships. We haven't discussed about the role of the tech industry. When I speak to people about AI and health, they said that it's people working on tech and apps. They're the ones that are deciding the data that goes in. And so I wanted to also say that I think it's very important that we have the patients, the health professionals, the public health people, the people who know about health also around the table. And I think for the next mandate, for me, the big issue is going to be about climate and health. I think we've only scratched the surface. I think it's difficult, it's complex, but I think the health sector as such, including the health industry, has a big role to play in also mitigating climate change. We are not looking at the food we serve people in the hospitals, the ambulances. You know, I think that as a health sector, we could also be bold in saying that we could also be at the vanguard of this movement. So I think that I would like to see that.
Thank you very much. You remind me, I interviewed one of the perm reps or country representatives of UNOPS, I think it was UNOPS, that was working in Ukraine, and in the context of maternal health and reproductive health, but also sexual violence, etc. And in the context of what happened in the first year, the medical infrastructure had to transform itself, and what they created was mobile units that were triage, that would go to different areas. Now imagine that. That doesn't have to be operable in a wartime situation. The future could be both digital, mobile, and local. There we go. Thank you. Thank you for that comment. Nasreen, what would you like?
I've got 2 points to wrap it up. One of which is that we should focus on what we have to gain by reuse of data for especially secondary purposes, much more than we do now, as we now focus a lot on privacy aspects and fears regard those aspects. We focus a lot on how we should protect citizens with opt-ins and opt-outs. But if we really want to talk about protecting citizens, we should talk about informing them and making sure they will be making informed decisions. And we should help them see the potential and also how this will benefit their health, because otherwise we're actually holding back what they could potentially benefit from in the future, and they might not understand the sacrifices that they're making by certain decisions. So that's one point. And the other point is there's a lot of innovation waiting on the shelves. We fund a lot of cancer research. Mostly they lead to some form of innovation, and I think approximately 80% remains on shelves, and we find it very hard to implement these innovations. There are multiple reasons, multiple obstacles that cause this lack of innovation, but I think that we might need some regulatory frameworks, for example, assessments of e-health applications, implementation helps, tools. We need to speed up this process from bringing innovations to market, and if we don't interfere, then we risk gradual or very different implementation along hospitals, and this makes all the tools less useful. So that we need to have some kind of regulations for this, and I hope we can think about that a little bit more another time, maybe in a sandpit.
Nasreen, thank you very much. Do you want to say anything in addition to what you've already contributed? You're more than happy, you're more than welcome, both of you, but you don't necessarily have to. You're a politician, we'll give you the mic. Yeah.
It's your fault. No, just quickly, just two requests. One for the current Commission, actually, and all member states. We have the pandemic accord negotiations ongoing. The vote will be in May 2024 at the World Health Assembly. Yeah. Please get it done and avoid the next pandemic. The second thing is regarding the future Commission. I would just say, reinforcing what I mentioned before, we need to define success in health, what it means to us in terms of KPIs, and then associate money to that and force the whole union to go in the direction. I don't believe we're going to have one system, but we can force everyone to move in the direction of quality of life and well-being, and using the money that we're giving away as a great incentive. Normally that pushes the system in the right direction if the indicators are right.
Absolutely, and as you say, if, as I was making the point to Fabiana about the resistance recovery fund, you need some form of anabolic steroid like that in terms of the quantum of that money to incentivize change, because health should be underpinning all of Europe, really.
But I mean, that's one of the biggest problems, because do you know what is the biggest source of funding from EU level for healthcare? Which EU source of funding is the biggest source of funding of healthcare?
Really?
Yeah. Which one?
I don't know.
Cohesion policy. So cohesion policy, more than 20 billion euros in one 7-year period. But we actually do not measure how these investments, usually into new hospitals, infrastructure, equipment, actually contribute to health outcomes. So I agree to what was said. Actually, I was a rapporteur in the Committee on Regional Development on how to use cohesion policy to reduce these differences in terms of quality of healthcare. And the main conclusion was that we have to measure actually the effects of how we spend European money. So definitely, I think that's one of the prime things. I think with recovery and resilience, that I'm not very optimistic that this will happen, because really member states are more or less doing whatever they want with that money. But that's a separate issue. But definitely we have to go in that direction. But the only leverage that EU has over healthcare systems, the most important leverage, maybe not the only one, but most important, is money.
Yes.
So conditioning money. So we give you money, but then you have to have concrete outcomes. So that's the most important thing. On the digital, yes, I wanted to make a point. What we saw with EHDS, we saw a lot of activists who have nothing to do with healthcare, coming and spreading fear that this will result in Facebook and Google taking our data, using it for social media profiling or whatever. So patient organizations are strongly in favor of the EHDS. They understand that with opt-in, this cannot work. So they supported our position on the opt-out. But people who have nothing to do with healthcare, who just wanted to score some political points on basis of this, with activists, actually created this fear that this will result in the stealing of data, misusing of data, etc. So we need to build trust. We need to inform the public on this, because without this, without having the trust of all parts of the system, so healthcare professionals and patients, this will not work. And this is why I think it's also important when you communicate to the public to explain why this is important. Thanks.
Tomislav, thank you so much. That notion of, wow, 20 billion on cohesion funds, and if you were to scratch the surface of an impact report, I suppose you get nothing, really. But thank you for bringing that to the table, because it's an important point also for, informing us about these dynamics. Colleagues, that's it. I've overrun now by 7 minutes, 8 minutes. I'm sorry, but I hope you thought it was worth it. We've had a fantastic panel again, I hope you think. Really kind of being able to take us to the skies and then bring us down onto the street, which is what we needed in discussion about health. The one thing we do know as a conclusion of this, I think, is that prevention matters. If there's one message you take away, is that prevention matters, and that actually health should be an economic and social good for Europe. And how we make that happen is through both incentivizing financially, but also most of the European public, if you do go look at survey after survey, want more and better on health matters from the EU. So it's got the best, if you like, public consensus across the Union for doing something on health, yet won't take the ambition forward and act on it under the guise of we don't have a competency in health. So we need to square that circle somehow, where the public feel about the EU and health and what they actually do. So let's hope the mandate listens. Thank you all for being here, because without you, we wouldn't have this conversation. And we mean it seriously. One of the things that we talked about earlier was a sandbox. If you want to get into a sandbox with us next year around health, let us know, because we'd love to do that. But importantly, we are launching our policy choices for the new mandate for a renewed social contract. For us, we think we need to think and shift differently about the expectations of government, the private sector and civil society, and we are framing that into a renewed social contract, which we're launching as a discussion in November, on November the 7th and 8th. So if you want to contribute to that, please get in touch. You have our email and you have our, our hashtag and you have our Twitter account. So please post your thoughts on what you'd like from the new EU mandate. Thank you all very much. Safe home. Please stick around, have coffee. No, there's no coffee actually. Stick around, go and take some good air and enjoy. Thank you all very much and thank you.